Hello, welcome to new episode of Case of the Month series. This is Deniz. I am the consultant pathologist, consultant gynecologic pathologist at HacettepePathology University, Department of Pathology, and I'm going to present this month's case. And this is a gynecologic pathology case. This is 34-year-old lady. She is admitted with OBGYN outpatient service with a complaint of palpable abdominal mass. And during the workup, contrast enhanced CT performed to the patient. What we have here, this is a contrast enhanced CT, and it is the level of the renal hilus. And this is a coronal plane, and we have 20 in here. We have 21 centimeter to 13 centimeter hypodense lesion over there. Let's get closer. And in axial plane, it is better you can appreciate this hypodense and heterogeneous multilocular mass. Also, in venous face, you can see some extensions to right ovarian. Here we have right ovarian vein and left common iliac vein. And also it has extensions to the larger vessels, inferior vena cava. And I am thankful to Esin. She's a former radiologist and now our pathology residents to helping me this interpretation of these radiologic images. Okay. Then what we have in microscopy, moreover in radiology report, it was stated that a mass was supplied by gonadal vein artery and internal iliac artery, has a dense collaterals, and what we have in lung parenchyma entering dissection has 1 centimeter multiple nodules, and it is very suspicious for metastasis. And to facilitate surgery or make it possible, the mass was embolized. Okay, in microscopy, what we have, this is a total abdominal hysterectomy and bilateral salpingo-oophorectomy specimen. What we have we have a diffusely infiltrating mass in the uterus, and it has some nodulations. Some large lobulations and some small lobulations, and it is diffusely infiltrating through the myometrium, and it has some sort of hemorrhage-like areas. Most of the mass has some tan white appearance, but we have some hemorrhage-like areas, and it is softened by palpation. And and we have, it is important finding, I think it's very important macroscopic finding, we have some small nodular miliary-like areas in the myometrium. I'm gonna get closer. This is miliary-like areas in the myometrium, and you can appreciate this tan white masses, micronodules and nodules in the myometrium. And here you can appreciate some sort of wall-like structures around those multinodules. And here you have like wall-like thing, and there's a cleft between this creamish area and this wall-like areas. Okay, so this is what we have in microscopy. The uterus weighted like 3 kilograms. It was 29, 23, and 13 centimeter dimension. Okay, I'm going to go through microscopy. What we have in low power, this is myometrium. You can see the large vessels of the myometrium, and you can appreciate this mass. What we have in this mass, it is composed of spindle cells, And in between those spindle cells, we have thickened vessels. We have thickened walled vessels in between those spindle cells. And there is a hyalinization at the background, and you can appreciate those spindle cells they look very bland. The nucleus of these cells look very bland. No mitotic activity, no mitotic activity, no necrosis is seen in this spindle cell lesion. And to me, it is like quite spindle, and it looks like smooth muscle differentiation. To prove that, we ordered some immunos. Before that, I'm gonna show you some other slides. Okay, let's go to, we have 20x in this microscope, so yeah. And here we have a wall-like structure over there, and we have this spindle cell lesion over there. And again, we have some sort of plug-like structures, plug-like spindle cell structures inside the vessel lumen. And this is also vessel lumen, the erythrocytes inside it. And we have, again, this nodular mass in the vessel. Okay, so again, this is a tiny ipsy little plug in the vessel. An interesting section. The sections are taken from these milieu-like areas, macroscopically milieu-like areas. It is important to sample those multinodular areas, micronodular areas. It is important to have those areas when you're sampling, when you want to prove that your lesion is not a sort of uterine sarcoma, to exclude this, to show all those structures are invading vessels, you should sample these micronodular areas that you see in microscopy. And what we have in here, again, we have a wall-like structures around this spindle cell neoplasia, and this area we have valve-like structures. So we are probably in the vein, and this is another section you can appreciate this beautiful, very bland and hyalinized structures of smooth muscle-like cells. So we ordered some immunostains, and the spindle cells are diffusely positive with H. caldesmin. And it is, again, diffusely positive with desmin. You can see here, no doubt. And we have in differential diagnosis of the spindle cell neoplasia has a affinity to the vessels. In differential diagnosis, we have low-grade endometrial stromal sarcoma. So we did CD10 stain. It is deadly negative. And what we did, it could be inflammatory myofibroblastic tumor. I know we don't have any myxoid areas, other sort of things, but it could be angioinvasive sort of inflammatory myofibroblastic tumor. This is ALK stain. It is, sorry for the dusts, and it is again negative. And yeah, we have a smooth muscle tumor in the vein and in the vessels. So this entity is intravenous leiomyomatosis. What we see in radiology, we talked about there is a there is a lung masses, 1 centimeter like lung masses, and it was very suspicious for metastasis. It is not metastasis. It is again the extension of this intravenous leiomyomatosis to the lung. And there is some hypothesis how it is originated. It could be originated from smooth muscle cells of the blood vessels, or maybe it could be originated from leiomyoma in the uterus, because most of the cells underwent some uterine surgeries such as cesarean section, and it could be sort of origin is smooth muscle cells of the blood vessels, or it could be leiomyoma invades uterus. And probably cells are ERPR positive. The neoplasia has ERPR positivity, and this ERPR positivity not seen in the vessel wall. So probably the second theory, the origin is the leiomyoma invades in the uterus. And the recurrence rates are differ. It is between 5% 4 to 30%, and regrowth is possible, like 20% different from the literature, like 60% to 30%, and it's the recurrence and regrowth is possible in this entity, and it is very rare. You can see like less than 400 papers in the English literature. And what happened to our patient? Our patient is now being evaluated by cardiovascular surgery and has an operation plan. And thanks to our surgeons, our talented surgeons, the patient is safe and sound right now, and she will be followed up after the operation for potential regrowth. Thank you for being here. Thank you for listening. See you next time. Bye.